Friends, welcome to my workplace at Ranaghat, West Bengal, India. This video is for teaching SICS to residents all over the world. First, apply few drops of povidone iodine 5% over the ocular surface and irrigate the ocular surface thoroughly with BSS or ringer lactate. Please don't neglect this step. Now turn the eyeball down with a muscle hook and hold the superior rectus tendon with this forceps and pass a thick nylon suture underneath the superior rectus tendon. This brittle suture will keep the eyeball turned downward. You will get a lot of space and the eyeball will be stable. This will act as your third hand. Now I am going to a little higher magnification, and this is conjunctival peritomy for about 2 clock hours, 11 o'clock to 1 o'clock. So the peritomy is done from 11 o'clock to 1 o'clock, and now bipolar weight field cautery. This measurement is 6 millimeter. My tunnel is going to be about 6 or 6.5 millimeter. And now this is bipolar weight field cautery. Cautery is done. This will help in making the tunnel with a lot of ease. And now I take a 15 number Bud Parker blade and place the incision. This incision is about 2 millimeter away from the limbus, and this is a frown incision. And now I take the crescent blade and start making the tunnel. Go forward at the center and now sweep backward and to the left. The tunnel has gone into clear cornea for about 2 millimeter. Now I come to center and sweep the crescent blade backward and to the right. At this time we must be careful not to cause premature entry or buttonholing of the anterior lip of the tunnel, anterior wall of the tunnel. And now this is a paracentesis at around 9 o'clock. Width of this paracentesis is about 1.6 or 1.7 millimeter. An air bubble has been injected, and beneath this air bubble, trypan blue dye is being applied over the anterior capsule, because this is a white cataract, and we can get contrast if we stain the anterior capsule with dye. And now this is a bit of adrenaline, and now the dye is washed out with the Simcoe cannula. This is a 23 gauge Simcoe, and we can see that the dye has stained the anterior capsule nicely. And now Visco is injected into the anterior chamber, and now I take a 23 gauge bent needle cystitome. Methyl cellulose is applied over the corneal epithelium. This improves visibility and the epithelium is protected. And now let us see the rhexis with the help of this needle. Raise a capsular tag and just guide this capsular tag in such a way that we get a fairly large rhexis. If the rhexis is large, about 6 mm, nuclear prolapse becomes very easy. However, if you happen to do a small rhexis, you can make a small cut and enlarge the rhexis with the help of utrata forceps later on. Rhexis has been done, and now some more visco is injected, and now is the time to open the tunnel completely. The corneal end of the tunnel is being opened. At this time, the keratome goes to the anterior extent of the tunnel, and then it goes downward, and thus the tunnel is opened from one end to the other end. The outer opening of this tunnel is about 6.5 mm, and the inner opening is about 7.5 mm. This is hydrodissection. In this case, I am trying to prolapse the nucleus by the hydrodissection cannula itself. I am going to keep injecting BSS or ring-elected. In this case, I am using BSS. As I am injecting BSS, at the same time I am rotating the nucleus, and it has come out of the capsular bag. And now is the time to deliver the nucleus. Visco is injected both anterior and posterior to the nucleus, and now this is an irrigating vectis. It goes behind the nucleus, engages the nucleus, and pulls the nucleus out like this. And the same irrigating vectis can remove the epinucleus in this way. So this is a beautiful way of delivering the nucleus. And now is the time to clean the cortical lens matter. %2 methyl cellulose is injected, and now I am using 23 gauge Simcoe cannula for removal of the cortical lens matter. Removing the cortex from 9 o'clock first, and now the antechamber is becoming shallow because visco has already come out. Now I go through the side port. As I start aspirating through the side port, the antechamber deepens, and I can remove most of the cortex except a few specks at 6 o'clock is remaining. But I cannot go through the main wound without injecting some visco. Yes, fill off the SE with visco, SE and capsular bag, and now as I go through the main wound, the visco will not come out immediately. It will take some time, and by that time the cortex has been removed. So whenever you need to go through the main wound, fill off the antechamber and capsular bag with visco so that the anterior chamber remains deep. Otherwise, if there is only fluid, if there is only BSS or ring-elected, and if you try to aspirate cortex, you may touch the corneal endothelium. And now is the time to implant an intraocular lens. In this case, we should have used a PMMA lens, but the PMMA lens of the appropriate diopter was not in our stock, so we are going to implant this lens. This is a foldable intraocular lens. The foldable lens can be implanted directly without folding, but I am using the injector. It becomes easier to implant the lens if we use an injector. I have made a small side port. A Sinski hook goes through the side port on the left side, and now the lens is injected. As the lens comes out, the Sinski hook supports the lens and places the lens in the capsular bag. The lens is rotated 180 degree, which has not been shown, and now the Visco is thoroughly removed from the anterior chamber as well as from the capsular bag. This is the Simcoe again. We can irrigate for few minutes. This is irrigation of the capsular bag, and now again irrigation of anterior chamber. Now irrigation and aspiration of the anterior chamber. So a thorough cleaning of viscoelastic substance is done so that post-op rise of intraocular pressure because of retained visco doesn't happen. This is moxifloxacin. Now the side port is closed by hydrating corneal stroma on either side of this step wound. And now is the time for the final lavage of the anterior chamber. Again, the BSS or ringer lactate is irrigated, and the anterior chamber is formed in this way. And now the superior rectus bridle suture is removed, and now is the time to appose the conjunctiva to the limbus. Many colleagues use cautery, but I use a releasable suture, and I can remove the releasable suture after 4 or 5 days, or even after 1 week. This doesn't cause a lot of irritation. It causes a very nice apposition of the conjunctiva. It goes like this, and now bite on the posterior conjunctiva, and now 3 throws will be used for the releasable suture. Let us see very carefully. Pull the thread, and now this is 1, 2 and 3. 3 throws, hold this suture and pull, and this is your releasable suture. Cut the thread with the needle close to the knot. Let the other thread be a little longer. As you pull the longer thread, it will come out. And now we are towards the end of the surgery. Subconjunctival injection of gentamicin and dexamethasone can be given. This will cause apposition of the conjunctiva more nicely, and moreover we are applying 2 medicines. That's it. The case is done. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.